Hello and good evening, dear delegates, for joining us today on this webinar. Today we have with us Dr. A.G. Unnikrishnan sir, who is a senior endocrinologist and CEO of Chelaram Diabetes Institute in Pune. Sir heads the clinical care, research, education, and also oversees the philanthropic and rural activities of the institute. Heads the Chelaram Diabetes Research Center, Innovation Center, and which diagnosis and management of the institute's e-learning academy. He has published the largest multi-center study of subjects with pancreatitis. Sir has published more than 200 PubMed indexed articles and has received multiple awards from societies like RSSDI, ESI. Dr. Unnikrishnan has edited various journals like Indian Journal of Endocrinology, Metabolism, Journal of Thyroid Research and Practice, and is the editor-in-chief of Journal of Chronicle of Diabetes Research and Practice. Sir is associate editor of editorial team of the International Journal of Diabetes in Developing Countries. Thank you, sir, for joining us today. Sir will be today speaking on the topic of synergy or minimize to maximize, adding sulfonylurea, DPP4, and a metformin combination. Over to you, sir. Thank you.
Um, Thank you, Dr. Pranav. It's a pleasure to be here. And I hope my slides are visible and that I am audible.
Yes, sir, they are visible.
Okay. So, first of all, it's a pleasure to be here. And this is a very interesting topic, how to have synergy to live well with diabetes. This topic is called minimize to maximize. How to minimize the number of medications, how to minimize the pill burden, minimize the medication while maximizing the benefit to the patient. So that's the point here. So this is a case, Mr. GM, a representative case. He is 52 years old. He has diabetes for 4 years. HbA1c is 8.7. The fasting is 144. The postprandial is 198. There is a history of hypertension. He is on glimepiride 3 mg, metformin 500 mg, and also another metformin 1000 mg. What do we do now? He is on glimepiride and metformin. Should you increase the glimepiride? Should you do something else to treatment? So do we have other options? So on that note, we are looking at this problem, which is not so uncommon that the patient's blood glucose level rises. On that note, diabetes itself is not very uncommon because you have almost millions and millions of people with diabetes in the country. And the glucose control is also high. For example, the average fasting is 8.56. The average HbA1c is 8.56. The average fasting is 172. The average postprandial is 253. So most of our patients have very high blood glucose levels. Now, if you look at the overall population, only 33% of people with diabetes have an A1C below 7%, which means the vast majority are not under control. 67% are actually not under control. They don't meet their targets. Now, the UKPD study, which is one of the major studies, and then there was another study called the GREAT study. All these studies showed that irrespective of the treatment that you give to your patients, the HbA1c is going to rise and rise and rise. And that is because type 2 diabetes is a progressive disease. And that progression has to be stopped only by one way, by aggressive diet, exercise, and prompt addition of medicines so that the A1C does not rise. So how to deal with this problem? Now we know that type 2 diabetes is not because of one reason. In fact, the ominous octet says that there are 8 reasons. There is a decrease in GLP-1, problems with adipose tissue, problems with kidney which reabsorbs glucose, there's decreased glucose uptake in the muscle, there's neurotransmitter dysfunction in the brain, there's hepatic glucose output and hyperglucagonemia. Itself is a new topic. GLP-1 and DPP-4 absence causes increased glucagon secretion and, of course, decreased insulin secretion and insulin resistance. Looking at the various multifaceted pathophysiological aspects of type 2 diabetes, it's rational to think that if you add a combination of oral drugs which targets each of these different pathophysiologies, that will have a benefit to your patient. So here's a thought. Each time you prescribe a therapy, initially you give diet and exercise, the blood sugar levels fall, it goes up, you add one drug, blood sugar levels fall, you add another drug, so on and so forth. This will cause a roller coaster of fluctuating glucose levels over time. But if you were to bring down the A1C early, hit hard, and keep it there, and keep titrating it so that the blood glucose level does not get a chance to come back up, that aggressive up titration, maybe with oral drugs, with more oral drugs, with basal insulin, with multiple daily injections, based GLP analogs, this sort of a earlier and proactive interventional approach that you see in the yellow color, that is likely to help our patients in the long run and prevent A1C from rising and rising. If you look at the American Diabetes Association's standards of care in 2023 and the American Association of Clinical Endocrinologists guidelines, both these endorse early combination therapy. In fact, they say that if the initial A1C is more than 7.5, then an early combination with two agents may be needed, especially those whose initial A1C is more than 9, then three agents may be needed. And it's also said that pharmacological agents should achieve and maintain the treatment goals and prevent failure. What are the advantages of combination therapy? By combination therapy, you are able to approach different pathophysiologies. You are able to prevent loss of beta cell dysfunction. You are able to reduce complications. You can counter therapeutic and clinical inertia. You can improve glucose control. You can improve adherence. So this is a new synergistic agent on the horizon, which is a combination of glimepiride, sitagliptin, and metformin. This agent is not new. We've had this agent for many years. But what is new is the presence of glimepiride, sitagliptin, and metformin in one pill. So that is the innovation that is there. And the primary consideration of treatment of diabetes is that we should be able to control hyperglycemia without hypoglycemia. Now, while glimepiride can control hyperglycemia and causes hypoglycemia, this hypoglycemia can be counteracted by sitagliptin and metformin in this combination, which does not produce hypoglycemia. So with glimepiride, if you remember, our patient had a glimepiride dose of 3 mg. High doses of glimepiride cause progressive beta cell failure. There is a higher risk of hypoglycemia. And that means that increasing glimepiride or sulfonylureas is really not a very good option. Then what should we do? But there is a rationale for lower dose of glimepiride. So instead of increasing the glimepiride, why don't we go for lower dose of glimepiride and optimize other agents? So the prolonged activity of such inhibition is able to improve, of this TP54 inhibition can improve both glucose-induced insulin secretion and decrease glucagon levels and results in maintaining beta cell function. Sitagliptin also is a complementary mechanism to sulfonylurea to improve glucose control. Sitagliptin is synergistic with metformin. While sitagliptin and glimepiride improve beta cell function, metformin can reduce insulin resistance reduce hunger and tackle glycemia at several other mechanisms. Addition of sitagliptin also helps in insulin secretion improvement without hypoglycemia and without weight gain. When sitagliptin is added to a slightly lower dose of glimepiride, then there is no risk of hypoglycemia because it's not sitagliptin that drives the hypoglycemia, it's a glimepiride. And if you lower the dose of glimepiride, not sitagliptin, you'll be able to get away with less hypoglycemia for your patients. And finally, sitagliptin, unlike glimepiride, which is said to torture and cause beta cell exhaustion, sitagliptin preserves the beta cell function as seen in studies evaluating the proinsulin insulin ratio. So can we, in this patient on 3 mg of glimepiride, can we achieve better control by decreasing dose of glimepiride and trying out the glimepiride sitagliptin metformin combination? Is there a study like that? Well, there is a study in India, and that's the only study of such a fixed drug combination study, in my opinion. It's conducted by the Sun Pharma. This is the phase 3 study of a combination of sitagliptin, glimepiride, and metformin that answers a very similar question to the patient that we saw in our practice in the presentation. Now, the objective of the study was to assess the safety and efficacy of sitagliptin phosphate, metformin hydrochloride, and glimepiride tablets in comparison to a co-administration of metformin and glimepiride in patients with type 2 diabetes. So one group, sitagliptin, metformin, glimepiride, the other group, glimepiride, metformin. This study was done in 392 sites across India, 30 weeks for the test arm, 18 for the comparator arm. The screening period was 2 weeks. The study treatment period was 28 weeks. The double-blind period was 16 weeks. So this was a study design. At screening visit, patients on a stable total dose of glimepiride 4 mg and metformin more than 1,500 mg for nearly more than 10 weeks were chosen. The A1C was between 8 to 11%. These patients were randomized into two groups. In one group, you had a sitagliptin 50, metformin 1,000, glimepiride 1 mg. This combination was given twice daily. And in the other group, you were given 1,000 mg metformin and 2 mg glimepiride twice daily with matching placebo. And the primary endpoint was a reduction in HbA1c. Note that this trial was unusual because it reduced the glimepiride dose from 4 mg to 1 mg with the addition of sitagliptin. And if the A1C was still more than 8%, the patient was up-titrated to 2 milligrams twice daily of glimepiride, 1,000 mg of sitagliptin, and 50 mg of, 1,000 mg of metformin and 50 mg of sitagliptin. In other words, they were on a twice daily combination of glimepiride 2, metformin 1,000, sitagliptin 50. This combination was given twice daily. So the study included people of either gender, aged 18 to 65 years with HbA1c 8 to 11 on stable dose of glimepiride 4 mg and metformin. The primary endpoint was a change in A1C, and there were a lot of secondary endpoints, which we will see. What are the phase 3 clinical trial results of this particular study? If you see the baseline characteristics, they were pretty similar. The proportion of males and females, the mean age, the height, the weight, the BMI, all these baseline characteristics were equally distributed. And when you looked at the efficacy result, it was shown that sitagliptin and metformin added to a reduced dose of glimepiride demonstrated superior efficacy. The A1C reduction was minus 1.79, statistically significant with a p-value of less than 0.0001. Very statistically significant results showing the superiority of the 3-drug combination of glimepiride, metformin, sitagliptin. Now, if you look at the mean change in A1C, in the treatment group of sitagliptin, metformin, glimepiride, you can see that from 12 weeks to 16 weeks to 24 weeks to 28 weeks, the A1C seems to be dropping and dropping and dropping. And at 28 weeks, you are seeing an A1C reduction of minus 2.37%. And that's on top of the pre-existing treatment of glimepiride and metformin. So friends, there is a reduction in HbA1c in patients who received sitagliptin, glimepiride, and metformin, 1000 mg twice daily for 28 weeks. And this was statistically significant. In fact, the A1C continued to fall, and that showed the fasting glucose came down very well by minus 54 milligram per deciliter. As you can see, at the end of 28 weeks, there was a sustained reduction in postprandial to minus 78.6 milligram per deciliter. And the proportion of patients achieving an A1C below 7% stood at 53%. So more than half your patients achieved an A1C of below 7% with the combination of glimepiride, metformin, sitagliptin, and the p-value was 0.0001. This is not just statistically significant, this is also clinically significant. So the efficacy conclusion was that the fixed drug combination of glimepiride and metformin was significantly superior in comparison to the co-administration of metformin and glimepiride in terms of A1C reduction at week 16. Let's look at the safety profile. Well, if you see, there was really no safety indicators. Hypoglycemia was really not significant between these groups. Therefore, this triple drug combination was safe and well tolerated. So the study concluded that the fixed drug combination of glimepiride, metformin, and sitagliptin was superior in comparison to the co-administration of metformin hydrochloride and glimepiride in terms of A1C reduction at week 16, and that the drugs were safe and well tolerated. So what is the fascination between glimepiride, low dose, sitagliptin, and metformin? And why was this very interesting result achieved? I think it's very clear. Glimepiride increases insulin secretion, and there is really an increase in cyclic AMP by incretin therapy. It potentiates the potassium ATP channel, and there is a independent insulinotropic action by secreting insulin and in a glucose-dependent manner. In other words, the glucose is high, glimepiride will still release insulin. The glucose is low, it will release insulin, but sitagliptin will release insulin only if the glucose is high. So this combination, because of sitagliptin, you get a glucose-dependent insulinotropic action, whereas glimepiride is glucose-independent, and metformin potentiates the action of DPP-4 by elevating GLP-1. Glimepiride and DPP-4 will decrease the glucagon levels. Metformin and sitagliptin will decrease the hepatic glucose output. Sitagliptin increases beta cell function, especially when added to glimepiride, and beta cell resurrection or regeneration is also improved with sitagliptin. And sitagliptin, when added to very low dose glimepiride, has been shown to improve glycemic control with no increased risk of hypoglycemia. So therefore, this combination improves glucose. There is little hypoglycemia. There is a synergistic effect. There is an improved beta cell function. There's a decrease in insulin resistance. There's a decrease in glucagon. There's an improved incretin effect. There are so many benefits of this combination. So coming back to this gentleman with type 2 diabetes, age 52 years, with diabetes for 4 years on A1C 8.7 despite glimepiride and metformin. We now have an option to decrease the glimepiride and add a metformin sitagliptin. So glimepiride 1 plus sitagliptin 50 plus metformin 500 or 1000 twice daily. This will reduce the pill burden. This will uh, uh, control the uncontrolled A1C. This is useful whether it's given at any stage of diabetes with ACVD or CKD. It prevents hypoglycemia and A1C can be quickly brought down. Friends, it has been a pleasure discussing this topic with you. And thank you so much for listening to me. I think such unique triple drug combinations reduce the pill burden, reduce the cost, improve the adherence, but most importantly, they approach the treatment of type 2 diabetes from a multi pronged angle because the pathophysiology of type 2 diabetes itself is multi pronged. So, from that perspective, they also reduce the glucose, do not result in any worrying hypoglycemia, and they will control our patients' blood glucose levels in the long run and hopefully prevent them from developing diabetes related complications. It has been a pleasure to discuss this topic with you. And thank you so much for listening to me.
Thank you so much, sir, for this wonderful lecture. Sir, we have a few questions from our audience. I would like to take them with your permission. Sir, one question is, what is the place of sulfonylurea combination with DPP-4 in the era of SGLT2 inhibitors, and what patient profiles will you prefer for such a combination of sulfonylurea and DPP-4?
Well, you're asking about a combination of only
Along with metformin, sir.
means sulfonylurea, DPP-4, metformin.
Yes, sir.
I didn't understand the question.
Sir, in the era of SGLT2 inhibitors, the triple combination of glimepiride, metformin, and sitagliptin, and what will be the patient profiles which you might prefer for such a combination?
Well, I think there are two, three answers to this. One is that patients who are already not having atherosclerotic cardiovascular disease or kidney disease risk would not be candidates for SGLT2 or GLP-1 therapy. Second is many patients are not able to tolerate SGLT2 inhibitors because of urogenital infections. These two categories immediately come to mind. And the third category is supposing a patient is taking all these drugs already as two, three different drugs. You can unify it by reducing the pill burden and making it simple for the patient.
Okay, sir. Sir, the next one is that what can be the role of this triple combination in the renal impairment patients, and if they have any role there?
Well, this triple combination can be useful in renally impaired patients, but remember when the EGFR falls, you have to adjust the dose of metformin. Below an EGFR of 45, you have to half the dose of metformin, and you will also have to adjust the dose of sitagliptin according to that. If you keep glimepiride, doesn't require dose adjustment, so you might like to keep that in mind. So it can be used. Use it carefully, keeping the EGFR in mind.
Yes, sir. Sir, the next one is that what will you prefer as far as the comparison between teneligliptin and sitagliptin is concerned?
Well, I don't use teneligliptin at all. Even when teneligliptin was launched, I rarely used it. So very rarely, for maybe one patient in maybe 3 months or 4 months, I may use teneligliptin. It's not a favorite because it increases the QTC interval. I've done some clinical research on teneligliptin where we showed that a gliptin can improve the time in range. That's a top TIR study. As a teneligliptin as a molecule, I prefer not to use because earlier there was a cost advantage. Now there is no cost advantage. Sitagliptin is economical today. Second, sitagliptin has a cardiovascular outcome trial, which teneligliptin doesn't have. Third, sitagliptin is not known to affect the QTC interval in the ECG, whereas teneligliptin might. So, given these things, teneligliptin not preferable compared to sitagliptin.
Yes, sir. Sir, the last one is, do you suspect any long-term adverse event with this triple combination, or you perceive it to be a safer combination as far as the
These
long-term
are
adverse
not new
events?
drugs. These are not new drugs. you already had glimepiride, you already had sitagliptin, you already had metformin. Now you are getting all the three into one pill. So conceptually, it's very difficult to imagine that this is having any problem in the long term. So I think it's easy to imagine that these drugs can be used in the long term, just like you would use them individually with good benefit to the patient. So yes, I believe they are safe in the long term.
Yes, sir. Sir, I think we have covered and all of the questions from the delegates. Now, with your permission, we thank you for this wonderful session, sir, and an opportunity to speak with you on this topic of synergy. And we thank all our delegates for joining us today evening and interacting with sir on this topic. Thank you, Team Sun Pharma. With your permission, sir, then we would like to proceed for closing of the session.
Thank you very much. It's a pleasure to be here and have a great evening to everybody. And thank you, Sun Pharma, for organizing this lecture.
Thank you, sir. Thank you so much.